Hello everybody, welcome to our next lecture on our chronics series. Today we're going to talk about type 2 diabetes, insulin resistance and deficiency in insulin. So at the end of this, you should be able to know what it is, the mechanisms involved, risk factors for it and prevention of it, how patients like this typically present, usual diagnostic criteria, complications and management in different settings. So what is type 2 diabetes? It is a chronic metabolic disease characterized by typically a triad of insulin resistance, progressive pancreatic beta cell dysfunction, and relative insulin deficiency. You'll understand all that in a moment. The triad of these three causes chronic hyperglycemia, which in turn causes chronically raised insulin. Insulin lowers blood sugar. If blood sugar is high, more insulin gets secreted. If your blood sugar stays high constantly, you're going to constantly have a raised insulin. This in turn causes your pancreatic cells to fail, in a sense. And that leads to metabolic dysfunction and can lead to progressive vascular damage. So, glucose physiology. After eating, carbohydrates get converted to glucose and blood glucose rises. Your beta cells in your pancreas secrete insulin. Insulin then in your bloodstream converts the glucose to glycogen. It gets stored. It shuttles glucose into muscle and fat to be used as fuel for their metabolism. And your blood glucose goes back down to normal. Easy enough. However, in diabetics, they get insulin resistance. Because of the chronically high insulin level, your tissues become less responsive to the insulin signaling, which needs more insulin to achieve the same effect. So more insulin needing the same effect leads to lowered glucose uptake, lowered conversion to glycogen, so less gets used and less gets stored, and that raises your constantly circulating blood sugar levels. In addition to this now, because you need more insulin to achieve the same effect, your pancreas can become quote-unquote exhausted from the increased demand for production, and then because of this increased production and the failing, eventually your production will actually decrease. And then hyperglycemia typically worsens because now insulin amount decreases, which means there's less of a lowering effect, so your hyperglycemia gets worse. Hyperglycemia gets worse, again, you need more insulin to achieve the same effect, which leads to more exhaustion, even more decrease in production. So what are your risk factors for diabetes? We're going to split them into modifiable, i.e. what you can change, and what you can't change. So you cannot change your age, your family history, your ethnicity, or gestational diabetic history. Pregnancy is a doozy, and sometimes people who get gestational diabetes just are diabetic from then on, unfortunately. Apart from non-modifiable is typically in research and practice, people of African descent tend to have a more pronounced risk for diabetes. Obviously, the older you are, the higher risk becomes just from age-related decline in function. And then those with a strong family history are more likely to also develop diabetes. Modifiable factors that you can now change are your weight. Losing weight means better insulin sensitivity, which means less risk of diabetes. Stopping smoking would be important. Having good diet quality, important. And then people who typically do not engage in much movement, i.e. those with desk jobs, sedentary lifestyles, more risk for diabetes. And if you have chronic stress and poor sleep. So what are our things to look out for? Many patients are actually asymptomatic. However, Symptoms that they can present with are typically polyuria and polydipsia, i.e. someone feels thirsty all the time, peeing a lot, if they feel chronically fatigued, if they have blurred vision, especially new onset, can be a sign of diabetic retinopathy. They recurrently get infections and poor wound healing. And then in some people, they can even get weight loss, which you'd think is good. And yes, the weight loss is good for insulin sensitivity. However, unintentional weight loss in a diabetic could be a sign of advanced disease. Because you have lowered insulin production, it means you get less glucose uptake, i.e. higher circulating blood sugar. Less glucose uptake, which means fewer calories are moved into your tissues, which means you are not maintaining your caloric balance. Workup. You typically do bloods. You would want to do an HbA1c. Normally above 6.5% is considered diabetic. However, it depends on your specific region, guidelines, lab, etc. Fasting glucose of more than 7 and random glucose of more than 11 with symptoms. Just because your random glucose is high doesn't mean anything. You could have had a meal half an hour ago. These are more sort of a guideline. HbA1c is especially helpful for monitoring purposes because you can track how well someone is doing with dietary changes and glucose control. HbA1c is in essence a summary, you could say, of the last 3 months worth of glucose. Then you get your oral glucose tolerance test. You initially do a fasting glucose, then you give a glucose bolus, and you retest it in 2 hours. Retest the blood sugar. If it is more than 11, it is highly suggestive of diabetes. Complications, primarily due to chronic low-grade vascular inflammation. You get microvascular and macrovascular changes. Microvascular, i.e. small blood vessels. Retinopathy can cause blurred vision and even blindness in advanced disease. Nephropathy can cause CKD and nephrotic syndrome. CKD is chronic kidney disease. Neuropathy is very common in uncontrolled diabetics. Get peripheral neuropathy with tingling and nerve pain. Autonomic neuropathy, i.e. sweating, variable blood pressures, essentially just dysregulation of metabolism. Then macrovascular complications are myocardial infarctions, strokes, limb ischemia, gangrene, amputations. So what is your management? I don't know if you've noticed, but most chronic conditions can be managed with weight loss, exercise, diet, and sleep. Weight loss of 5 to 15% can improve insulin sensitivity, reduce your HbA1c, and can lower requirements of medication. Exercise, 150 minutes a week minimum of aerobic exercise with additional resistance training. And then having a diet with high fiber food, healthy fats, vegetables, fruits, and lean proteins. Baseline. Avoid sugary, simple carb foods. And then 7 to 9 hours of sleep nightly, ideally. So, what medications can we use? Metformin is normally the go-to. 500 milligrams once a day, up to either 1 gram twice a day or 850 milligrams thrice a day. In my experience, most people who are placed on 850 3 times a day typically do not take the middle dose, so I prefer to prescribe 1 gram twice a day. Metformin reduces your hepatic glucose production, so typically if you have a low circulating blood glucose, or more on the low end, your liver causes some gluconeogenesis to cause your glycogen to be converted into glucose to be used in tissues. This occurs very commonly at night, especially. Um, so metformin reduces your liver's conversion of stored glycogen into circulating glucose, and this in turn improves insulin sensitivity. It is, for most people, weight neutral, or it could even cause some mild weight loss. And it is also cardiovascularly protective by activating your AMPK pathway. Then you get SGLT2 inhibitors, such as, I can't say those words, you can read them on the screen. It increases urinary glucose excretion. So less glucose gets used and absorbed, means more gets peed out. Can lead to mild weight loss, mild reduction in blood pressure, and is heart failure protective. However, because of the urinary glucose excretion, people are at a higher risk for UTIs. Then you get your sulfonylureas, such as your glimepiride. You can see the doses on the screen. It requires a working pancreas to be effective. It forces your pancreas to produce more insulin. The problem with this is, number one, it's not suitable for type 1 diabetics as they need a functioning pancreas, and it has a higher risk of hypoglycemia compared to your SGLT2 inhibitors. Typically, people who are on a sulfonylurea and insulin are high risk for presenting with hypoglycemia, especially in the mornings. Then you get your DPP4 inhibitors, such as sitagliptin, dosed at 100 milligrams daily, and then your GLP therapies, which help with weight loss and appetite regulation, but also directly increase insulin production. That's your liraglutide, semaglutide, tirzepatide, and the soon-to-be approved retatrutide. And then lastly, the final boss of diabetic medication, so to speak, insulin. The core problem with type 2 diabetes is either a lack physically of insulin or just not enough insulin for an effective dose. So, how can you circumvent that? You give insulin exogenously. Normally used in severe hypoglycemia, those with catabolic symptoms, i.e., those with advanced disease and weight loss, and if lifestyle interventions and oral medications have not worked. Um, the reason insulin works for catabolic symptoms is because insulin itself has anabolic properties, hence why it is used very often by bodybuilders, especially around their training windows. So, what are our common regimens? Again, it depends on your specific site, region, country, and such, and what insulin you have available, and what your patient actually needs. But typically, you get two types of insulin, your three. So your long acting, your short acting, and your ultra short acting. Long acting insulin is normally dosed at 0.1 to 0.4 IUs per kilogram per day as a baseline. It has to be titrated to match the fasting glucose targets of the patient. It's normally split into 2/3 in the morning and 1/3 at night. Common names for these are your glargine, your protophane, and opticillin. You need your short-acting insulin, which depends on your glucose targets pre and post meal. Typically dosed either at the meal or up to 30 minutes before the meal. Base amount usually is based on what their glucose was upon waking or pre-meal. Actrapid, Epidra, and glulicine are typically these ones. And then you get a combination of short and long-acting insulin, usually for ease, usually people with more rigid schedules or with basically those who don't really want to inject multiple times a day. So they would typically do this around their largest meals of the day, normally breakfast and supper. It's a combination of their basal bolus with their short-acting insulin for that meal. These are typically actrophanes and novomixes. Diabetes, while a chronic condition, can also cause emergency presentations. An example of this is your diabetic ketoacidosis, called DKA. It's more commonly in type 1 diabetics, but can be in type 2 diabetics. It's a triad of hypoglycemia, ketosis, and acidosis. Typically, you diagnose it by dipstick to see if there are ketones in the urine with a glucose more than 25, and if they are symptomatic: headaches, dizziness, abdominal pain, acidotic breathing. Those are some of the common symptom presentations. However, just because your glucose is not more than 25, if you have ketonuria and symptoms and a high glucose, it's still the DKA until proven otherwise. Definitively, you want to get a blood gas, but in most primary care facilities, ketonuria, high glucose symptoms is all you need to diagnose it. So what is your management of a DKA? Insulin, fluids, monitoring. Fluids: 1 liter normal saline over 1 hour, then according to your volume status. Patients often require 4 to 6 liters of total fluids. Again, the regimen specifically depend on your facility. Then you get insulin boluses: 10 IUs of your fast-acting insulin, that's your Act Rapid, as needed to bring your HTT to less than 20. Again, sometimes, especially people's HTTs are above 30, they may need up to 5, 6, 7 doses of their insulin. And then, or alternatively, you can do an infusion. Typically, infusions are done in more of a hospital ICU setting, and that is at a 0.1 IU per kg per hour IV infusion, obviously with regular glucose monitoring. Insulin is an important molecule at your kidney level for holding on to electrolytes. Insulin signaling causes your body to keep more sodium, keep more potassium. So if you are giving insulin, it is important to check your potassium. Sometimes you can overshoot it. Sometimes typically people with the amount of fluids that they're getting, have a low potassium. If potassium is low, you can replace it with 20 to 40 millimoles of potassium chloride per liter of fluid. Not given all at once. Give it slowly over half an hour to an hour, retesting your potassium, making sure you do not give someone an arrhythmia, please. Your other diabetic emergency is called HHS, hyperosmolar hyperglycemic state. It is a bit less common than DKAs, but it has a higher mortality rate. Usually because it is less common, so it is less managed effectively. It is characterized by glucose that is typically unreadable because of how high it is, severe dehydration with high osmolality, and maybe minimal to mild ketosis. You need aggressive fluid resuscitation and an insulin infusion of 0.05 IU per kg per hour. Again, it depends on your specific facility and guidelines. And then hypoglycemia, which is the other end of the spectrum. It is defined as glucose less than 4, with severity of the presentation increasing the lower the glucose goes. People normally present unconscious, dizziness, confused. If they are conscious, you can give oral glucose replacement of 15 to 20 grams of a simple carb, powdered dextrose, sugary cool drinks, glucose tablets. Or if they're unconscious, you should ideally give IV glucose or dextrose, 50 ml of a 50% dextrose solution. If the patient is unconscious and you cannot achieve IV access, you can give 1 milligram of glucagon injected IM. It stimulates the release of your stored glucose into the bloodstream. But what's also important that you can do is your buccal mucosa is quite thin, and glucose moves past that very quickly. So you could smear like your powdered dextrose glucose tablets on the inside of the mouth, around the gums, cheeks, and glucose can be absorbed that way. So what is our take-home message? Type 2 diabetes is fundamentally a disease of insulin resistance and pancreatic cell dysfunction. Weight loss is the primary lifestyle modification that works in diabetes. Metformin is going to be prescribed as the foundation of your therapy for all of your type 2 diabetics. And then your all other medications are adjuncts that are tailored to fit the patient. SGLT2 inhibitors and GLP-1s provide cardiovascular and renal protection in addition to helping glucose regulation. At every visit, screen for retinopathy, nephropathy, and neuropathy, i.e., test HbA1c, test creatinine, do a visual acuity test, ask about symptoms of tingling, joint pain, paresthesia, numbness. HHS is the most important acute emergency, although not necessarily the most common. And then prevention and early intervention are a lot easier than treating established complications. It's a lot easier to bring an HbA1c of 8% down to 6 than it is to bring an HbA1c of 20 down to 10. And that is type 2 diabetes in a nutshell. Thank you for listening.